All right, so I'm going to get started. Good morning, everybody. I'm Clara Chow. I'm here to talk about therapeutic advancements in pediatric neuromuscular disorders. So my disclosures, I participate in some advisory boards and am a sub-I for several research trials. So the objectives of my talk today are one, to review the common disorders in the field of pediatric neuromuscular disease, discuss new FDA-approved medications and analyze the clinical trial data, and then lastly, identify some of the complexities in navigating the new treatment landscape. So as far as a background to this topic, in general, for neuromuscular disorders, we've been seeing a lot of new therapeutic developments, and it's really been exponential more recently. And because of this, there's new aspects of disease that we're noticing now, and in general, treatment goals have been changing. There are a lot of challenges to this in terms of finding biomarkers as well as tracking clinical improvement and how do we do this. And it's become very complex because we don't know now what we consider as first line. How do we approach things like combination therapy? How do we factor in things like cost as well as ethical concerns? So I created this table just to highlight how many new therapies are now FDA approved. So back in 2015, and here are just some of the disorders that I've decided to highlight. The ones that are in bold actually have pediatric FDA approvals. So just looking down the line, ALS, for example, back in 2015, only had one drug. Now there is four. With CMT, really the same. We don't have any FDA approvals for CMT. There are new trials that are ongoing for CMT, and so govorestat is one for SORD deficiency, which potentially may be available. With CIDP, primarily treatment is IVIG that have FDA approvals, but now we have two more drugs, and one is actually an FcRn inhibitor, but that's only available for adults. With Duchenne's, which I'm going to be spending a lot more in detail today, we had no FDA-approved medications back in 2015, and now we have, I believe that's 9 available, plus a potential one that's coming later this year. With Guillain-Barré, similarly, we have no FDA-approved medications, even though we use IVIG and Plex as sort of standard of care. There is one that's kind of potential coming out that's going to be going into a phase 3 trial in the US, and this is actually a complement inhibitor. With Lambert-Eaton myasthenic syndrome, we had no FDA-approved medications back in 2015, and then now we have imifempridine, which is something that's available for peds since 2023. With myasthenia gravis, back in 2015, we've had pyridostigmine for a while. We use a lot of other medications sort of off-label. And now, especially in the adult side, there's a lot of specific medications we have FDA approved. And just this year, we've gotten 2 new ones added for pediatric indications. I'll be talking about those. And then lastly, with SMA, back in 2015, we had no medications. And now there's 3 FDA approved medications with the potential pending 4th. So the first category I'm going to talk about is with Duchenne muscular dystrophy. So this is an X-linked recessive disorder. It's the most common neuromuscular disease of childhood. Typically, boys present with delayed motor milestones. They have proximal weakness, calf hypertrophy, and then eventual loss of ambulation. They develop restrictive lung disease, cardiomyopathy, and early death. Pictured here on the bottom, you can see a typical boy with Duchenne's with the phenotype that you're seeing. And then this is actually a picture here done by Duchenne that was published in Muscle and Nerve. And so in general, the natural history of Duchenne's is that typically, diagnosis is around 5 years of age, and that's still pretty much about the same now. But over time, because of progressive muscle loss, you will lose standing ability, you lose ambulation, and then eventually you have to be ventilated, and then you have early mortality. And so in general, steroids have been sort of the mainstay of therapy for a very, very long time, and it does change the course of disease. But now we have some more things available. So with DMD, this is caused by mutations within the dystrophin gene, and the dystrophin gene has 79 axons, which is one of the largest genes in the body. And when we diagnose these boys, typically they have very, very elevated CK. Usually it's greater than 10,000, and we can pretty easily do genetic testing to confirm. Treatment in general is still a comprehensive multidisciplinary approach, and there are several articles that are published as far as what diagnosis and management should be for these boys. I have them over here on the right, but you can see that these were published back in 2018. So in general, these are pretty old now, but we still reference these a lot for comprehensive care. And back in 2021, Broomfield actually published some median survival ages. And you can see over the years that survival has definitely improved over the years. So back if you were born before 1970, your median survival was around 18 years. If you're born between 1970 and 1990, your median age is 24 years. And then if you're born after 1990, your median survival is 28 years. And this is 2021. So that's before a lot of some of these drugs we have available now. So it's probably continued to improve over time. So I created this table just to sort of summarize the medications that are now available for Duchenne's, because it is a bit overwhelming and there is a lot to keep track of. So I categorized each one based on sort of the type of drug. So the first category up at the top are the corticosteroids. And so now we have three available. Prednisone has been around for a long time. We still use that. Back in 2017, we have an FDA approval now for deflazacort. And then more recently in 2023, we have vamorolone. And so this is indicated pretty much for all boys 2 years of age and older. And the mechanism for these are slightly different, and I will be talking about vamorolone a little bit as far as commenting on why this is a little different. They all come in oral suspensions. Some of them do have tablet formulations, but they're taken, most of them, pretty much on a daily basis. We do sometimes do a high weekend dose therapies for prednisone and deflazacort, but vamorolone is just daily dosing. The next category of drugs we have available are these antisense oligonucleotides or exon skipping agents. So we have 4 currently FDA approved. These are now semi-old now, but these are really only indicated for certain gene mutations. And the way that they work are to try to restore the reading frame to create more dystrophin. And these are IV medications. They're given on a weekly basis. I'm actually not going to be talking about these today just because there's other ones that I wanted to focus on. Then we have the histone deacetylase inhibitors. So this is givinostat. This got FDA approval back in 2024. This is approved for boys 6 years of age and older. And I will be talking about this one in more detail, but it's an oral suspension. It's given every day and it's dosed based on weight. You have to give it with food. And then lastly, we have gene transfer therapy, which is delandistrogene moxeparvovec, which has gotten a lot of press lately. And I'll talk a little bit about this and why. Right now, this is FDA approved for boys 4 years of age and older, and this is an AAV type therapy, which is a one-time infusion. So first off is corticosteroids. So like I mentioned, we have these 3, and pictured up at the top here is just the chemical structure of these and how they are all very, very similar. But vamorolone, this is considered a first-in-class dissociative steroidal anti-inflammatory. And the reason they have this is because it does bind the same receptors as prednisone and deflazacort. It binds the glucocorticoid and the mineralocorticoid receptors. But instead of being an agonist like prednisone and deflazacort, it actually is an antagonist at the mineralocorticoid receptor. And so because of that, it has some new features for it. It has less bone toxicity. It helps with height. And so I'll talk a little bit about why this is potentially beneficial. So the clinical trial that led to its approval was this trial here. This was a randomized double-blind placebo and prednisone-controlled clinical trial. They looked at these boys over the course of 48 weeks, and they did do a crossover at week 24. And so pictured on the bottom left here, the dark blue line, they did 2 doses of vamorolone. So there's a high dose vamorolone, and then there's a lower dose vamorolone here in the light blue. And then the gray here is placebo. And so graft is basically the stand from supine. So the faster you are, the better it is. Light turned off. So basically, you can see like the higher dose vamorolone, there is an improvement and it gets sustained over the course of the 48 weeks. versus the lower dose didn't perform, but it's still effective. And then placebo, there's really a plateau and slight worsening over the 24 weeks. And then graph here on the right just shows that the dark maroon color here is the prednisone group. So these boys first received prednisone, and then at week 24, they crossed over to receive vamorolone. And you can just tell that it's basically similar as far as its effectiveness to vamorolone. And it really does, even when you switch over, maintains the similar efficacy. So the benefit of this is that it seems like it improves linear growth, and these boys are able to maintain their height. So down here on the left, this is the height Z-score. So same colors, the dark blue here is the vamorolone high dose group, and you can see these boys continue to grow over the course of 48 weeks. Versus the maroon here, which is the prednisone group, they do not, and their height basically plateaus. And then on the right is after you cross over. So the maroon here is the prednisone group. They maintain their height. And then once you cross over to vamorolone, they are able to somewhat catch up, even though they don't quite reach the group that initially started on vamorolone. And so apart from linear growth, the other benefit to this is that it seems like it helps with bone health. And so the serum biomarkers that they use to look at bones, like osteocalcin and P1NP, as well as bone turnover markers, showed that these got worse with prednisone, but this did not happen with vamorolone. Both do have very similar rates of adrenal suppression. So there's still a lot of unanswered questions with this drug. First of all, it seems like there should be less growth and bone side effects, but we don't know anything about things like fracture risk, scoliosis risk, and how it affects the age at loss of ambulation. We also don't really have any long-term outcomes. We don't know its effect on respiratory function as well as cardiac function. So like I mentioned earlier, vamorolone does have a mineralocorticoid effect. And so does that provide some cardioprotection? We don't know that. And we don't know really its effect on mortality. So there is an ongoing phase 4 registry that's happening now, and PCH is currently a site. So hopefully some of these questions will be answered in the near future. And then lastly, the role that it can potentially have in other conditions, like Becker's or ulcerative colitis and myasthenia gravis, we don't know. And this is potentially something that could be available for those in the future. So the next drug I'm going to talk about is givinostat. So this is the histone deacetylase inhibitor. So in DMD, we know that there is increased histone deacetylase activity, and that leads to basically a reduction in the expression of genes involved in muscle regeneration. And in the mouse models, they found that givinostat was able to increase cross-sectional myofiber area, and it decreased inflammation and fibrosis. So the phase 2 trial was able to show in biceps biopsies that they were able to increase muscle tissue fraction, and it reduced the amount of fibrosis and necrosis. So that led to the phase 3 trial, which is this one pictured here. This is Apidus. And so this is a randomized double-blind placebo-controlled trial. And this was actually a 72-week study, so it was quite long. They were able to enroll 179 boys, and these were boys with Duchenne 6 years of age and older and who were already on steroids. And pictured here on the top is a forest plot, which shows that basically most of the primary and secondary endpoints favored givinostat. And so you can see up here, there's several different function testing, strength testing, MRS scores. All of these favored the drug compared to placebo. And then on the bottom here, you can see graphed givinostat is this pink red line, and then blue here is placebo. And this is the 4-stair climb. And so in general, over the 72 weeks, you can see that there is still worsening, even if you're given givinostat, but it's much less compared to if you just received steroids. The side effect profile overall is tolerable, except there is some GI side effects. It can affect your triglycerides as well as your platelets. So we do monitor those. Okay, lastly, we have gene transfer therapy. So the issue with gene transfer, specifically with Duchenne's, is that with AAV vectors, the carrying capacity of AAV is limited to 4.7 kilobases. And the DMD gene is large. It's about 2.4 megabases, and so it doesn't fit into an AAV vector. And so they found a kind of interesting solution to this. Back in 1990, there was a family that was published that had very mild Becker's muscular dystrophy, and the proband was actually ambulating with this stick at age 61. And they found out that this family, their mutation was a deletion of exon 17 to 48. And this was an in-frame deletion, and 46% of the coding region was deleted, and they still had this very mild phenotype. And so this led these companies to basically create a microdystrophin gene, which is a much smaller version, using kind of mimicking this to try to create a milder phenotype. And so each drug company basically has their own microdystrophin gene, and they're all slightly different, but the idea is the same in that they're trying to create a much smaller version microdystrophin so that they can package it into an AAV vector. So the clinical trial that led to this approval is the EMBARK trial, and this is a phase 3 randomized controlled trial. They treated 125 boys. These were aged 4 to 8, and they use an AAV RH74 vector. So the primary outcome that they used was the North Star Ambulatory Assessment, which is sort of a, multiple things that we look at in terms of motor function. And unfortunately, with this trial, it actually was not statistically significant at the end of the study, which was at week 52. And you can see pictured here on the right. So here's a forest plot showing that it does not meet its primary endpoint, but with some of these secondary function testing, they were able to show that there was statistical significance. And so this is actually quoted from the paper. It says, some of the secondary endpoints numerically favor treatment, although no statistical significance can be claimed. And then the next quote is also from the same paper. The global statistical test, a composite measure of efficacy, supported the totality of evidence of treatment effect. And so they argued that because in general, overall, it seems to show improvement, that even though it didn't meet their primary outcome, that this is beneficial. So the question, when this first came out is, why didn't this meet primary endpoint? And there's different hypotheses regarding this. One is that potentially the disease progression is heterogeneous, because between this age 4 and 7, these boys can be still improving. They can still be gaining motor skills. They can be in their plateau phase where they're maintaining, or they can be starting to decline. And so it can be difficult to, in a clinical trial setting, figure out where they are in this potential period of time. The other thing is that, this is relatively short, so maybe it wasn't long enough to show that there was an improvement. And then they also get daily steroids. So during this gene therapy period, they're on higher dose of steroids. And so there was a hypothesis that potentially that the higher steroids was what was causing the improved muscle strength and function over the short term, and not because of the drug. Lastly, North Star, it is a good scale we use, but potentially in this population, it may not be sensitive enough. But in general, it had a very favorable safety profile, and at the time, there were no life-threatening events, there were no deaths, no study discontinuations, and so this actually got the first FDA approval back in June of 2023. After that, the story for this drug has become a lot more complicated, and so in June 2023, this drug got the initial FDA approval, and it was just approved for aged 4 to 5, and it got this approval through the accelerated approval pathway. In June 2024, FDA expanded this approval, and so it was approved for all boys 4 years of age and up, and it actually got the traditional approval for ambulatory patients, and then the accelerated approval for non-ambulatory patients. So we started treating, we have treated a lot of these boys now, but then in March of this year, there was the first official death that was reported in a 16-year-old non-ambulatory boy, and this was caused by acute liver failure and intracranial hemorrhage. So when this happened, there was a big press release. Acute liver failure was added to the product insert, but we kind of continued on knowing that this was potentially a side effect that could happen. And then June of this year, there was a second death, and this was a 15-year-old. He was also not ambulatory, and this was caused by acute liver failure. And so when the second case happened, Sarepta, which is the drug company that creates this, temporarily suspended this product for all non-ambulatory boys. And then just last week, last Saturday, we learned about its third death. This is actually not in a boy with Duchenne's, but this is a 51-year-old male. And so this drug is also currently in phase 1 trials, looking to use it for limb-girdle muscular dystrophy, but they also had a death there from acute liver failure. And so when this came out on the 22nd, which was last, I believe, Monday or Tuesday, they completely suspended this drug. And so we can't actually get it anymore until they look into more of the safety profile for this. I actually had a patient that was scheduled to get this tomorrow, and it didn't happen. And so this is, in general, just been a pretty roller coaster of experience for how this has rolled out. So what are the adverse events? So in the initial clinical trials, there were no life-threatening events, deaths, or study discontinuations. And now we're knowing that acute liver failure can happen. They say that there's been over 800 boys that are currently treated with this drug now, and we've had those 2 deaths in Duchenne's. So graphed here is sort of the adverse events that we see and the timeline of when they happen. And we think that a lot of this has to do, one, with the AAV vector. It has to do with your innate immunity as well as complement-driven immunity. And so typically in the very beginning, like the first week of after infusion, the primary things that we see are rhabdomyolysis, and then we see some cardiac events like myocarditis. We can see fever, nausea, vomiting. After that 1 week, the next big category are these liver events, and they typically happen at around 1 month after infusion. And so we can see transient liver enzyme elevations, and even in the initial studies, it's a pretty large amount. So it's about 40% of boys who will get transient liver elevations. But hepatotoxicity and then liver failure can also develop because of that. And so this typically happens kind of in the second month after. And the hard thing is, when we see these adverse events, there's no standard of care as far as how to treat or how to approach these. And so, we think that because of these liver events, we should be increasing the amount of steroids we give them. There's potential talk about increasing immune therapy and using things like sirolimus, tacrolimus, things like that to help with that. But really, we have no idea. And there's really just basically cases of some of these events and how to treat them. So they did, with this drug, there is some longer term data that are now published and sort of talked about from posters. So at 3 years out, they were able to pool 50 patients, and they showed that there was long-term stabilization and slowing of disease progression compared to a matched external control. And that included the North Star ambulatory assessment and other functional testing. They also have 5-year data. So there were 4 patients from their initial trial that they've been following, and they showed statistically significant and a clinically meaningful difference in these same motor scales. And so here, these are pictures taken from the posters. So like North Star, for example, here, the dark purple here is the group that got treated, and you can see that they basically they improve and then they maintain over the entire course of the 5 years versus the external control cohort, natural history, and even with steroids, there's worsening. And you can see that also with other timed function testing, like time to rise, as well as like the 10-meter walk run, that over time, the boys that the external controls will get worse versus there's relative stability with the boys that are treated with this gene transfer therapy. So lots of unanswered questions. We don't know why some of these adverse events happen. They've tried to look into correlations with things like age, weight, comorbidities, and there isn't anything to be found quite yet. We also don't know anything about the respiratory and cardiac outcomes, which they were going to look into, but we don't know what's going to happen to this drug now. Risk versus benefit. So this is a big question. And, before they pulled this drug out of the market, this was a very big conversation that we would have to have with our families because, what is the risk? Could be a significant risk as far as death within, a month of getting this treatment versus what are the benefits? And so there was a question about doing informed consent. We didn't really do that here, but there were other institutions who would have to get informed consent to be able to give this treatment. And then, like I mentioned earlier, there's no standard of how to treat some of these adverse events. There's other trials going on, and even with this drug that talks about some of the alternative immune therapies that could potentially be used with AAV delivery to see if they can improve some of the side effect profile, but that is still unknown at this point. So the costs of these drugs. So I use drugs.com just to get a general idea of the cost of these. These are all obviously very, very expensive. So vamorolone, for example, if you were to be given a max dose of this, which is a daily steroid, it would cost you $273,000 a year. Givinostat, which is an add-on therapy, so this would be given in addition to your steroids. Max dose of this, it's a oral twice a day dosing. This would cost about $1.2 million a year. And then with the delandistrogene, the gene transfer therapy, this is a one-time infusion, and this was 3.2 million. So this was the most expensive drug that FDA had approved up to at that point. But this price tag does not include everything else that goes along with it. So the amount of time that we spend with the families, all of the clinical follow-up. So the way that we had it set up was after these patients got dosed, we would have weekly clinic visits with them. They would get their labs before coming in. We would review their labs with them, and it would be weekly for about 3 months. So it was a lot of time, a lot of effort, a lot of coordination. And, this isn't even talking about the adverse events and how to manage them, because some of these boys we've actually had to admit. There's actually one, I think, admitted right now with acute liver injury. So these are all very, very expensive drugs, and it's going to be more and more expensive. And especially when we talk about combination therapy and adding things on, it's just going to be more and more and more. Okay, so moving on to the next disease category. So I'm going to talk about juvenile myasthenia gravis. So the incidence of JMG is variable, but in general, we think that it's about 10% of all myasthenia gravis for pediatrics. So juvenile myasthenia is an autoimmune disorder. It causes autoantibodies against proteins in the postsynaptic membrane at the neuromuscular junction, which includes acetylcholine receptor, MuSK, and LRP4. The clinical phenotype is that it creates a fatigable weakness. It can include ocular weakness like ptosis and diplopia. It can involve bulbar weakness with dysarthritic dysphagia, as well as limb, axial, and respiratory weakness. There was a recent systematic review published by Lin in 2023 that was able to describe these clinical features of JMG, and it summarized 11 articles. There were 1,100 patients in these articles that were diagnosed between 2006 and 2021. And they found that JMG occurred in about 60% female. The mean age was about 7.4 years. 64% of them are prepubertal, 35-ish% are postpubertal. And that ptosis is the most common initial symptom in about 78%. Most of these patients were treated with pyridostigmine. Some were also started on steroids, and then some were treated with other immunosuppressants. Thymectomy is one of the treatments we can use, and it was performed in about 46% of these patients. And in general, thymoma is much less common in juvenile myasthenia than in adults. And we also see in general, there's a much lower mortality rate in children. So when we talk about juvenile myasthenia, there's several treatment considerations for us. So one, we have to dose based on weight. And when we use steroids, we have to think a lot about the side effects for these, how it affects growth and things like that. There's also risk of malignancy. So with immunosuppressants in children, we have to think about that. There's also a lot higher rate of spontaneous remission compared to adults. And so it changes how we approach the treatment regimen for kids. There's no formal guidelines, and a lot of the practice is taken from adult guidelines and expert opinions. And so before this year, typically the treatments that we use, these were all off-label. And so we would use pyridostigmine, we had prednisone, there were steroid-sparing agents, we could perform thymectomy, IVIG, plasma exchange, and rituximab. Now, since this year, we have 2 new FDA-approved drugs in pediatric indications, and that's eculizumab and nipocalimab. So the treatment targets, when we talk about myasthenia, this is a diagram that shows some of the targets. So first of all, your B cell creates these autoantibodies. These are Ig immunoglobulins, and one pathway is that these IGs will activate your complement system. And so when that happens, you get significant immune response. And a lot of drugs are targeting sort of this complement inhibition system. And I'll talk about one of these, which is eculizumab, but there's several other ones that are in clinical trials as well as approved for use in adults. The other pathway is immunoglobulins will go into this FcRn recycling pathway. And so some of these drugs are FcRn inhibitors, and I'll talk about some of the mechanism for why this works. There's some upstream targets here looking at, CD19 and IL-6 inhibition, which these are all still in clinical trials. And then off onto the left here, we have these acetylcholinesterase inhibitors like pyridostigmine that we use to help with improvement and increase of acetylcholine in the neuromuscular junction. So eculizumab, so this was initially approved for adult use in 2017. So it's been available now for a while, but it finally got the pediatric indication of 6 years of age and older who are acetylcholine receptor antibody positive. So this is a first-in-class human terminal complement C5 inhibitor, and the way that it works is that it blocks the C5 protein into becoming C5a and C5b, and it prevents the activation of the membrane attack complex. Eculizumab is actually approved for other indications, and even in peds, we use it for paroxysmal nocturnal hemoglobinuria, atypical hemolytic uremic syndrome, as well as neuromyelitis optica spectrum disorder. So this isn't a new drug, but there are other C5 complement inhibitors that are approved for adults, and that includes ravulizumab and zilucoplan. These two are not available in peds yet. So the trial or the study that sort of led to the FDA approval in peds was this one here. So this was a phase 3 open label multi-center study, and it looked at adolescents aged 12 to 17 years who had refractory acetylcholine receptor antibody positive GMG. And you can see graphed, the one on the top here is QMG scores over the course of the trial or the study, 26 weeks. And then on the bottom is the MG-ADL score. So these are just different scores that we use that has to do with myasthenia symptoms. And so the higher the score, the worse you are. And you can see pretty much within this first 4 weeks, there's a dramatic drop in improvement in your score with treatment, and that effect gets sustained over the course of the full 26 weeks. And on the right here are the responder analysis curves, and you can see 70% had a greater than or equal to 5-point reduction in their QMG, and then 50% had a greater than or equal to 3-point reduction in their MG-ADL. So it's a very robust, very quick improvement with this drug. And so in these 11 adolescents that were studied, all of them met their primary and secondary endpoints, and it was sustained throughout the 26 weeks. So eculizumab is weight-based. It has an induction period, and then it's given as a maintenance IV infusion every 2 weeks. There is a black box warning like it has for all of the other indications for serious meningococcal infections because of the mechanism of the complement inhibition. In general, adverse events are very mild or moderate and thought to be unrelated to eculizumab. Really, in all ped studies, it's a small number. There's a limited age range, and particularly in this study, there was no placebo control. But in this cohort, 3 patients were able to decrease their corticosteroid requirement by the end of week 26, which is a pretty big deal. And the indication now for this, it's FDA approved for 6 and up. And so the 6 to 12 years approval came from safety profile in atypical HUS. So the next one is nipocalimab. So this is now approved for pediatric patients 12 years and older who are acetylcholine receptor or MuSK positive. And nipocalimab is a fully human monoclonal antibody, and it binds to FcRn to block recycling of IgG. So how these drugs work is that you have your IgGs circulating in your blood, and when they go into the cell, they go into these endosomes, and your FcRn receptors are this red here, are attached in these endosomes. And when your IgG binds to the FcRn receptor, it gets recycled. And so it gets pushed back out into circulation. And that's partly why IgG has a long half-life. It's around 28 days in circulation. And that's primarily because of this mechanism of FcRn recycling. The IgGs that don't bind to FcRn will go into the lysosome to get destroyed. And so these drugs are FcRn inhibitors. And so the way that they work is that your drug, which is this light blue, will bind to the FcRn inhibitor so that it does not bind to your IgGs. And when it doesn't do that, all of your IgGs will get degraded in the lysosome and it doesn't go back into the circulation. So in some ways, this is basically trying to clear out all of your IgGs from circulation. And so there are other FcRn inhibitors that are approved in adults like efgartigimod and roxanolixizumab. These are not available for peds yet, but there's more. So the study that led to this approval, I have this is the adult study, and the ped study actually isn't even published yet. But in the adult study, there were 77 patients that received nipocalimab and 76 patients that received placebo. And you can see here on the left, this is graphed the IgG concentration. And the blue is the treatment group, the red is placebo. And so very dramatic, pretty much within 2 weeks of initiation, there is a drop in your IgG levels. And that gets sustained throughout the entire course of 24 weeks in this study. Similarly, with looking at MG-ADL and QMG scores, you can see that there is an improvement of these pretty much within the first 4 weeks, and then it gets sustained to a statistically significant difference. And same down here with your QMG, that there is an improvement within kind of the first even 2 weeks of starting the drug, and then it gets sustained with a statistically significant improvement. So the adolescent data, like I mentioned, is not yet published. There were 7 adolescents aged 12 to 16 that were treated, and we actually had one, Dr. Burns had a patient from here in this trial, woohoo. So basically in the adult or adolescent population, similar to the adults, that they had a similar reduction to serum IgG to 70% from baseline. And there was a reduction in MG-ADL and QMG scores noted by week 4, and that was sustained throughout week 24. And 4 of those 5 patients were able to show minimal symptom expression by week 24. And adverse events overall were very, very mild. This trial was done in the middle of COVID, and so a lot of the adverse events were related to COVID and nasopharyngitis. So as far as costs go, similarly, these drugs are very expensive. So eculizumab, if you were to be given the max dose, which you get the max dose once you're 40 kilos, it's given every 2 weeks, and this costs approximately $725,000 a year. Nipocalimab, we don't even know how much this costs yet. But efgartigimod, which is the same mechanism as nipocalimab, I used kind of as a proxy, but if you were to get this as a max dose, this would cost about $475,000 a year. And so these are all very, very expensive drugs. And if you kind of look back at the initial diagram with the mechanism, these drugs act downstream. And so this doesn't affect antibody production. So technically, if you're not in remission for myasthenia, you will be on these drugs forever. And so it's long-term use. And so over the course of somebody's lifetime, these drugs can be very, very expensive. And so you have to think about that as far as how to choose and, deciding on the costs for some of these things. Okay, so last category, spinal muscular atrophy. So spinal muscular atrophy incidence is about 1 in 10,000 in the US. The carrier frequency is about 1 in 50. The first description of this was back in the 1890s, where they described infants who had severe progressive weakness, and they developed respiratory failure and early death. So the clinical features of these, typically there's hypotonia, there's progressive weakness, bulbar weakness, and then intercostal weakness as well, with relative sparing of the diaphragm. So you get this bell-shaped chest in these babies. And there's 4 primary types of SMA, which we still kind of reference, but don't really see anymore. But just to get an idea, type 1 is the most severe, type 4 is the most mild phenotype. The most severe form, the infants are unable to sit without support, and typically they die before age 2. Type 2 is milder. They're able to sit, but unable to stand or walk without support. And so they may gradually develop issues with respiratory, and these patients also typically have early mortality. And then type 3 and 4 are the more mild, which they can walk but may need assistance, or they develop symptoms in adulthood. So the mutation for this is caused by a homozygous deletion in SMN1 gene, and it's about 96%. And we do newborn screening now for this, and that's how it gets detected, is through this SMN1 gene. But we do have to remember, 4% of patients do not have this homozygous deletion, and so will get missed on newborn screen. And so when you have loss of SMN1, you rely on SMN2, which is a paralog gene, and it differs from SMN1 just due to a C to T change in the splicing region of exon 7. And so because of that, the amount of protein that gets made is much less. And so it's a much less efficient way to make SMN. And when you have deficient SMN protein, it causes lower motor neuron death. So there is an association with how many SMN2 copies you have in your phenotype. So ideally, the more SMN2 copies you have, the less severe you are. But this is sort of a loose, association. But we do use this to kind of predict, to see what kind of SMA type you may have. So with treatment for these, right now we have 3 FDA-approved medications. Some of these have actually been around for a while now, and we've been using these. So nusinersen had its FDA approval back in 2016. This is approved for all ages. It's a SMN2-directed antisense oligonucleotide. This is given intrathecally every 4 months. Risdiplam is an oral medication also approved for all ages, and this is a SMN2 small molecule splicing modulator to improve SMN2 efficiency. And this comes now in tablet formulation as well as an oral suspension, and it's dose based on weight up to a max dose. And then lastly, we have onasemnogene apavarvovec, which is Zolgensma. This is the gene transfer therapy using AAV9 vector. And so this delivers the SMN1 gene to replace that. And it's a one-time IV infusion, and it's given between 0 and 2 years of age. So the first one is nusinersen. So there's now, since this has been out for a while, there's a lot of trials that have been done, as well as some that are still pending. But I just tried to summarize this instead of going through each one because there's a lot. But in general, the big trials are the ENDEAR, CHERISH, and Embrace and Nurture. And each of these kind of looked at different SMA types, looking at infantile onset, later onset, and then pre-symptomatic infants. And overall, there is a statistically significant improvement in motor milestone response. There is event-free survival, and a lot of these trials were actually stopped early because of how effective they were, but the drug works really well. There are some newer trials that are ongoing. One is DEVOTE, which is sort of looking at higher doses of nusinersen. So right now we have the same dose for everybody, regardless of your age or size. So if you can imagine, a newborn can get the exact same dose as a 50-year-old. So it's a pretty dramatic difference, and they still get the same dose. And so the higher dose trial now is ongoing, and that's DEVOTE. There are 2 other ones looking at combination therapies. So looking at infants who previously received the gene transfer therapy, who now are getting nusinersen, and then those who were previously treated with risdiplam, which is the oral medication, and now transition to nusinersen. So these are still pending as far as what their clinical outcomes are. With risdiplam, similarly, this now has been out since 2020, and they all work. The trials were all named after fishes for some reason. So firefish, sunfish, jewelfish, rainbowfish, and all looked at different SMA types, looking at infantile onset, type 2s, pre-symptomatic, and all of them had a statistically significant improvement. And I just pulled kind of 2 graphs showing this one is from sunfish here on the bottom left, looking at if you were treated with this drug, you had an improvement in your scores versus placebo, which decreased over time. And then same with upper limb function, there was an increase in your score over the 12 months versus in placebo, there was worsening. So these are all very positive results that we've seen from all of these trials. And then lastly, with onasemnogene apiparvovec, so this is the gene transfer therapy. There were 3 main trials, START, STRIVE, and SPRINT. All of these looked at different SMA types, those under 2 years of age, those under 6 months of age, and then those who are pre-symptomatic. And they all showed very good clinical outcomes. Here on the bottom left is just a graph from the STRIVE trial. You can see that the survival probability is the green one here if you were treated versus those who were not treated in the natural history. And then on the right is looking at CHOP INTEND scores, which is their motor function. And you can see over the course of this 20 months that there is an improvement in the scores in those who were treated versus down here on the bottom is this gray, which is the untreated natural history, which gets worse over time. So with these drugs, these are also very expensive. Nusinersen, typically in the first year, because of the loading doses, would cost about $750,000, and then it would cost $375,000 per year after. Risdiplam, the oral tablet, it costs $1,100 per tablet. And so over the course of the year, it costs about $413,000. And then onasemnogene moxaparvovec, this is the gene transfer therapy, one-time IV infusion, which costs $2.1 million. And just like with, Duchenne's and their gene transfer therapy, this doesn't include like all of the time because we see a very similar adverse effect profile with this, and these patients we still will follow and see pretty much on a weekly basis for about 3 months after infusion. All right, so to summarize, reflections, since this is my 3rd year now as attending, I picked the right subspecialty. So neuromuscular medicine definitely is the most exciting field, I think, and treatments have become a lot more complex and expensive. But I feel like the treatment landscape for neuromuscular medicine is definitely at the forefront, and I think there's going to be more of these therapies, especially those that are going to be gene targeted, that will be available for other subspecialties and even other disciplines. And there seems to be recurring themes because even for us, with SMA and Duchenne's, we are seeing some very similar adverse event profiles. And so over time, as these become more available and AAV vector therapies become available, we're going to see these more and more and more. The other thing is a lot of this patient care happens behind the scenes. And so there's a lot of coordination, a lot of lab monitoring, scheduling, insurance approvals, takes a lot of time. And so we have a very great team here, and I'm very lucky to be able to be a part of it. Here are my references, and that's it. I could take any questions.
That was excellent, Clara. Thank you for doing that. Wonderful, wonderful. I put this in the chat, but I can just ask you directly too. You had the question about the eculizumab, or the mention that you have to have a need for meningococcal vaccination.
Mm-hmm.
And so I was just curious, and since I've been noticing this so much in this time of so many children who are unvaccinated, what do you tell a family? Would you tell a family they couldn't get the medication if they decline that vaccination?
Yes, they have to have it.
No question.
Yeah, no question. If you need to start the drug before vaccine, because you do need to get the drug or get the vaccine 2 weeks before starting. But if like you really, really need the drug, like you're really severe, you can give it, but you have to give prophylactic antibiotics. And so, yeah, no question, you have to get the vaccine. Let me see, I'm just looking at the chat. Yeah, so all of these AAV vectors are slightly different, and I don't know the question to that, whether it's because of this AAVRH vector that's causing the hepatotoxicity, but we actually see hepatotoxicity even with SMA. So with AAV9, we see hepatotoxicity. So it's not that it doesn't happen with the other ones. So I don't know if it's inherent to the vector itself or if it's more the patient population that we're treating, that this seems to be more severe when liver failure happens. I don't know. IV, yeah. So that's great question as far as yeah, so that potentially could be a potential solution to this is so Zolgensma or the gene transfer therapy for SMA, they are looking at intrathecal dosing for this because it's a much lower dose that they can give since it's going straight to the CSF. And so that potentially could bypass some liver toxicity and liver clearance, but we don't know we don't know if that's still ongoing as far as research goes. The hard thing I think with intrathecal is, with SMA, we can, yeah, like with SMA, we can do intrathecal dosing, but with things like Duchenne's, you can't really because you're trying to get to the muscle. And so that is true that some can bypass the liver, especially if you're given intrathecal.
Are there any more questions? I don't think there's any more questions. Thank you so much for being here this morning.
Thank you.